So this is a patient that was being put to sleep for an appendectomy, and before the ET tube could be put in during the induction, the patient vomited and aspirated a significant amount. Here you can see the aspirate within the airways during the bronchoscopy after the tube was put in place, and you can even see that the ET tube is quite soiled. So the patient during the surgery was on 100%. They were having problems with oxygenation. They were able to maintain SATs around 88 to 90. So in the recovery room, while we waited for an ICU bed, I put the PulmoVista, and you can see in the PulmoVista, initially I don't have the initial images, but most of the ventilation was going to the ventral regions. We tried some recruitment maneuvers, and we could see that there was some potential to open up the dorsal regions, but it required high pressures. So during the recruitments, we were able to somewhat open up the dorsal regions, but then after it would close up. We tried PEEPs up to 14 and 16. Again, it did improve, so we knew there was like potential to open up the dorsal regions, but the ventilation was quite aggressive, and we didn't want to shoot ourselves in the foot and have issues of lung injury, getting a better SAT at the moment, but then after causing lung injury down the road. What was happening too is while we were recruiting the dorsal regions, there was a large amount of distribution to the ventral regions, and you can see that with the current PulmoVista image that we're looking at, that white bar, that white intensity, because the white aspect within the blue shows where the majority of the ventilation is going. And you can see that there's a large amount that was going to the ventral regions. So what I suggested was that we, once the patient was in the ICU, that we put the patient in a prone position. So this image, while I've been talking here, this is actually about an hour post-op on APRV. So, we're talking about poor distribution to the dorsal region, but actually it's pretty good compared to what it was before. I just don't have that image. The FiO2 requirement was no longer 100% after an hour. We were able to get it down to 85%. So putting the patient in a prone position had, theoretically, this was the idea that I had. If you're flipping the patient into the prone position, now you have the ventral areas that are somewhat compressed by the body weight. Therefore, when the vent power goes into the lung, it's kind of splinting the ventral regions and protecting them from overdistension. And that allows a better possibility of the dorsal region to be recruited and to remain recruited. So there's somewhat of a protective aspect to the ventral regions by flipping. Also, the majority of ventilation is going to the ventral regions. So by flipping the patient into the prone position, the gravity dependent area becomes the ventral area, because now you have blood flow because of gravity going to the ventral areas. So that way you can optimize the ventilation to perfusion. So the image here that you're seeing, it's actually APRV. We have a P high of 20, which is very safe. We don't have high pressures at this point. We have a T high of 5, and a P low of 10. It was around like 9 or 10. And we had very brief releases where we were releasing only to 75% of the peak expiratory flow and then returning up to the P high level. We have the patient on APRV. We have a slope of 0.3, P high of 22. Do an expiratory pause here to see the P low. P low is 10.8, so that's a safe drive pressure. 473 for tidal volume. With the Draeger, if you increase the slope, you will get a larger tidal volume often. Just let it go down for a couple. 635. So the slope has a significant effect on tidal volume. We'll bring that back to 0.3. You got to watch out as you increase the slope. You'll get better tidal volumes, but you'll also lower the mean pressure sometimes a little bit. This is what his tomography looked like in the recovery room. So there is some dorsal distribution, but I didn't film the other one, but there was an issue where we're having trouble. We're often losing the dorsal area, and when we were increasing the vent power, there was maximum ventilation going to the ventral areas. So we're scared of, over the coming period of time of ventilation, by continually adding pressure to try and keep this open here, that we might be over distending or putting more pressure there. So what we're going to do is we're going to prone the patient. It's well indicated because the FI2 is actually, you know, quite high, and by flipping it, we know that there's good ventilation here, so that'll redistribute the blood over here. It'll kind of splint this area and hopefully facilitate to keep it recruited. So that's where we're at this moment. So he's been about an hour on APRV. It is better now, but you see here the majority of the ventilation is over here. So we're gonna flip him and we'll see the distribution of ventilation, what it looks like once he's prone. So this is on APRV, patient's now prone. You can see the chest hardly moves.
Yeah, no, I don't think so. I'm so sorry.
We're still having nice ventilation, down to 75%. We're gonna wean a little bit more. We're just still getting the patient all hooked back up. And now this is the patient in the prone position. So we've gotten exactly what we were hoping. Now we really have a wonderful distribution of ventilation now that we proned. And we'll let the patient settle in and we'll see from 85 if we can wean down further. But the pressures are very safe. So the P high, which is kind of equivalent to the to the plateau. So we have a plateau of 20. Do an expiratory pause here. Freeze the waveform. And we got about 10.4 for the P high. Good stuff. All right, so here's a freeze frame. Beautiful distribution. The white is pretty well distributed. I'm not worried too much about the little bit more ventilation going to this area. I mean, we have a P high of 20, so we're down to 35% from 85. 85 had like a SAT of like 90, 92. Okay, so we have a SAT of 97, and that is on 35%. We can almost go down almost a little bit more on the P high, because we have beautiful distribution of ventilation here. We can probably even go down a little bit more, and that we already have a delta P of 10 because the P low was 10, so 20 and 10. We can almost go down to 18 now. Extremely safe parameters. All right, 35%. That's like, sorry, I'm like super excited because we went from 85% prone the patient. Now we're at 35, and we've probably weaned down even more.